Good evening and welcome to Meet the Professors Live. Clinical investigators provide perspectives on actual cases of patients with ovarian and endometrial cancer. Due to unforeseen circumstances, Dr. Love will not be attending ASCO this year, and we truly miss him. The good news is he's okay. He's doing really well. He wishes he could be here with you all tonight. In his place, my name is Dr. Angeles Alvarez Secord. I'll do my best. I'll give you the little Caitlin Clark love sign right there. And we are joined by a wonderful, wonderful faculty this evening from all over the country and world, actually, right? So joining us this evening, we have Dr. Flora Bacchus, Dr. Mansoor Mirza from Denmark, Dr. Ritu Salani from California. Dr. Flora Bacchus is from the Ohio State in Ohio. Dr. Brian Slomovitz from Miami, and then I'm from North Carolina. So we really cross the country and part of the world. And then we have this wonderful group of contributing general medical and gynecologic oncologists as well. And that's Dr. Eric Lee, Dr. Lyndsay Willmott, Dr. Priya Rudolph. So I want to introduce everybody using their titles, but we want to be really informal here, so we're also going to go by our first names. So in order to make this meeting much more relevant, that's why we invited our general medical and gynecologic oncologists, and they're going to be sharing their own cases with us today and asking questions directly to the faculty. Here are our relevant faculty and research to practice conflicts. This is all provided for you. We'll keep. And Dr. Love's disclosures as well. So this program does contain discussions of non-approved uses of agents and regimens. Please refer to the official prescribing information for each product for the approved indications. And Research to Practice is hosting a total of 9 live meetings. I believe we're the 6th one. And all these meetings are associated with ASCO 2024. We hope that you'll be able to attend the rest of the events either live or virtually or the next 2 days. You can see that Monday we'll have colorectal cancer, metastatic breast cancer, and then there's a bispecific antibodies in the management of lymphoma. This is where we're headed this evening. We're going to start out with Ritu giving a discussion regarding upfront treatment of advanced ovarian cancer. Flora will discuss the current management of relapsed and refractory ovarian cancer, promising new strategies and novel therapies. Mansoor will discuss first-line therapy in advanced endometrial cancer. Brian, current therapeutic options for relapsed and recurrent endometrial cancer, novel investigational strategies. And I'll finish things off with the role of HER2-targeted therapy in the management of advanced ovarian, endometrial, and other gynecologic cancers. So I'm so excited to ask Eric or Dr. Lee to come up now and present our first case.
Okay, I want to thank the organizers for allowing a community of medical oncologists like me to present these cases to the faculty panel up here. Our first case, a 64-year-old woman with mild dementia. She was originally admitted to the hospital with a bowel obstruction and perforation. And on XLAP, she was found to have peritoneal carcinomatosis with ovarian cancer. Subsequent workup shows that she has a somatic BRCA1 mutation. She was treated with carboplatin paclitaxel, first cycle without bevacizumab. She seemed to tolerate that well, so I added bevacizumab, completed 6 further cycles. She was seen by a gynecologic surgeon who did not feel that she was a candidate for debulking because of delayed healing from her original XLAP. She had a complete response on PET-CT. Her tumor markers normalized. So I put her on maintenance therapy with bevacizumab and olaparib. She then developed an appendiceal perforation 3 months later. Bevacizumab was discontinued. Interestingly enough, when she went for surgery, there was no evidence of cancer. Surgeon wondered whether it was actually an adhesion from her original surgery that caused the perforation, but I do not know whether it was actually from the Bev. She continued on olaparib for 3 further months. She then had a restaging scan that showed a sidewall recurrence, and she's pending workup for a repeat biopsy for me to send for folate receptor alpha testing. So some questions for the faculty. First question is, how would they have managed this patient post-operatively? This patient presented with effectively an abdominal perforation. Question for the faculty would be, would they consider this to be an absolute contraindication to using bevacizumab?
Yeah, so this is not just one GI perforation, this is two, right?
She originally had the first perforation on presentation. This is when she was treatment naive. And then after about 6 months, maybe 7 months of therapy, she developed a second perforation that was not thought to be due to the cancer.
All right, Ritu, how would you have managed this patient postoperatively?
Yeah, so this is a patient, these are always challenging cases. And, for me, doing both surgery and chemotherapy, typically the bowel perforation would probably have been a hard stop for me for administering bevacizumab. I also, you probably wonder, was it the disease that caused the initial perforation? So her bowels are definitely stressed out from the disease. That puts it at higher risk for perforation. And I know you had mentioned that she didn't have disease at the time of her second operation, but her bowels were probably still compromised. She also presented with a bowel obstruction, right, in her initial presentation. So it would have been a hard stop for me with bevacizumab. It's easy for me to say that now, right? So I know these are challenging cases, and I'm going to talk a little bit about the use of bevacizumab. I think the other thing is she had a somatic BRCA1 mutation, and so the role of PARP inhibitors is really clear as maintenance. I'm not really sure what the bevacizumab adds in that case, so I would have probably held off, but...
Yeah. These are all great discussions, and thank you for sharing this case with
absolutely.
us. Just wondering, Brian, can you talk a little bit about contraindications to bevacizumab beyond what Ritu mentioned?
Yeah, so with bevacizumab, obviously in this case, but then there's also, uncontrolled hypertension is something that I'd be careful of with bevacizumab, as it could increase blood pressure. And thromboembolic events. It used to be if you had a blood clot, we never would consider bevacizumab. In my practice, I'm a little bit more liberal if it's they have a DVT, but they're on anticoagulation and they're doing really well with it. I think bevacizumab is a good drug. And we all think bevacizumab is a good drug, and there's definitely a balance when not to use it. But those would be situations that I would consider not to. But again, everyone's different.
Yeah, thank you. Eric, I think you have some more questions for us.
Looks like they already moved on to the next slide, but I guess the question is, in what situation would you include bevacizumab as upfront therapy? I say, excluding a bowel perforation.
Anyone want to take that one?
Yeah, sure, I'll start. It's my topic, so I'll take the liberty. I think it's still an emerging field. I think as we're starting to think about biomarkers in ovarian cancer, I think the patients who have a somatic BRCA mutation, clearly the PARP inhibitors play a better role. The HRD negative patients, I think bevacizumab still plays a significant role until we have something better. So those are the ones that I'll kind of preferentially treat, but I'm always looking for clinical trials because I think we can still do better.
Thank you so much. I'm going to just take some license here. Give me some grace. I'm going back because I think there's an important question here. All right, so here we go. This one I want to highlight because it's about how long you continue the olaparib. So Mansoor, how long would you continue olaparib in the frontline setting?
So the data is for 2 years, so it will be for 2 years. Simple.
All right, and anybody else there?
Anything else?
Yeah, anybody else have a comment there?
No, I think, we have that data that 2 years is effective, and it continues on. The effect and the curves and the overall survival continues on. Even though the patients stop at 2 years, we still see that big difference between the curves, and they don't actually converge again. They stay very nicely separated and actually separate more. So, the niraparib was studied as 3 years, but the results for all these trials are very similar. So we're going to see a trial coming up is actually 1 year better than 2 years, or not better, is 1 year equal than to 2 years of olaparib treatment. So we're going to shorten that time and see if we can still see the same benefits. But for now, it's 2 years.
Yeah. The good thing is that we haven't seen that increase of MDS and AML in the first line, which is very comforting.
Yeah. The reason why I used to like thinking keep it on as long as you can. But the reason why now I stop at 2 years is because there's some preliminary data that came out yet, and I think we're going to learn more. If you need to retreat them with PARPs, the patients do better on retreatment with PARPs if they completed their course. So if they completed their course and they need to start again, then it's okay. But if you're on a PARP and they recur, there's really probably not a role of retreatment with PARP. So that's why I like to stop now. It's against what I used to do.
Yeah, I agree.
Yeah. Fantastic, all fantastic points. All right, well, I think we need to thank you again so much for presenting that case. We're going to switch over now. Lyndsay's going to come up and present her case. You know, I don't know about all of you as Lyndsay comes up, but I have patients that come to clinic and they don't want to stop their PARP inhibitor, and it's getting really tough to have that conversation. So maybe more on that later. All right, Lyndsay, thank you so much.
No, thank you, everyone. It's a pleasure to see everyone on this beautiful Sunday night here in Chicago. I feel like your conversation is going to segue very nicely into my case, which is a 44-year-old woman who presented with advanced ovarian cancer. She did undergo an upfront cytoreduction and then was placed on adjuvant chemotherapy with carboplatin and paclitaxel. She had testing performed to assess her for any mutations, and she was noted to have a germline BRCA1 mutation. And so therefore, following completion of her platinum doublet chemotherapy, she had no evidence of disease, and she was subsequently started on olaparib maintenance. And she did very well. She actually completed 2 years of maintenance and then had 2 years prior to evidence of recurrence. So I think one of my most important questions is your strategy for testing. How do you talk to patients about it in the clinic, and do you test simultaneously, or do you like to do sequence testing based on results?
All right, let's see. Brian, do you want to take that one first?
Yeah, sure. So in all of my, that's a great question. In all my newly diagnosed patients with ovarian cancer, I definitely do germline testing in all of those patients because, again, not for just the patient, but their family members, we want to know if it's hereditary. I'm also, in my practice now doing next-gen sequencing, which I think is important information to look for targetable mutations then and potentially in the future. And finally, I'll do HRD testing if the germline testing is negative. So I don't do if they're germline positive, then there's no role, but if they're negative, then I'll do HRD testing to see if they're a candidate for the Powell regimen or a role of PARP inhibitors in their maintenance therapy.
And Lyndsay, I like your next part of this question. Could you throw a little zinger in there?
Yes. Yeah, and I think this is, for me, one of the questions that comes up a lot when a patient does have a germline mutation. The question then becomes, how do we speak to the family members? So I'm curious, how do you do that? How do you talk to them about making sure that their family members are being tested?
What about you, Flor? How do you do that?
Yeah, I think this is one of our opportunity for us to really do that cascade testing and talk to the family members and offer risk-reducing surgery. But it requires a lot of education. I think there's still such a misconception. We miss the opportunity to let the patients know it's not just the females. Every patient, so most of my patients will be like, I only have daughters, or I only have sons, so I don't really need to do anything more. But giving an opportunity that it should be male, female, everybody needs to get tested if that's in the family, with opportunities for preventative measures, whether it's risk-reducing surgery or intensified screening with mammograms, MRIs, and things like that, and awareness, very, very important. So yes, absolutely bringing it up.
No, I totally agree. I can just see Ritu wants to say something, so.
I'm sorry?
I was like, can I say a comment? She goes, it's too late. I just want to actually add to Brian's comment earlier about the NGS and germline testing. I totally agree with that. And now you can get commercial assays that are actually testing for things that you might use in the future, like alpha folate receptor testing, and even now HER2 testing, which we're going to talk about later. So I think it actually informs, and we don't know how it changes over time, but I think it's actually kind of a nice idea to have because we know many of these patients will recur. So I'd like to just add about IHC testing and mismatch repair testing as well for some of those patients.
All right, Lyndsay, you have more questions for us too.
Yeah, I think probably we all can agree that one of the most challenging groups is our homologous recombination proficient patients. So those patients are candidates for consideration of PARP inhibitor maintenance in the upfront setting. We know that there is probably less of a benefit in that patient population. But how do you talk to patients about that, your HRP patients?
Yeah, I'm going to have Brian talk about this one first because I know that you and I have had these discussions several times.
Yeah, so, right now it's really been simple for me. And those patients with homologous repair proficient, obviously BRCA wild type. I don't offer PARP inhibitors in those patients. In those patients, I'd err on going with bevacizumab maintenance therapy if there weren't any contraindications like the first case. But I could try to keep it simple in those cases.
Really? Okay. Anybody offer a PARP inhibitor for patients who have proficient homologous recombination?
It's still out there. Like, I do oftentimes the same thing, but I keep looking at the data and I look at the hazard ratios for bevacizumab with chemotherapy and the bevacizumab maintenance, and we're looking at hazard ratios of 0.8 or something like that. And then we have the PARP inhibitors that have actually a little bit better hazard ratio, even though the numerical numbers are so close, but we still see that separation. So I haven't completely excluded it for the HRP population. And now also it's our only opportunity for these patients to get a PARP inhibitor. So if I don't treat them up front, it's not, but it's still evolving what we're going to do. But it's harder, I think, now that you don't have it in the second line anymore.
Mansoor?
Yeah, I agree. I just want to add to what you just said, Flor. Think about sequencing. The HRE negative disease or HR proficient disease is a tough disease, and quite many patients may end up to progress within 6 months. So if they have received bevacizumab, they cannot receive PARP inhibitor after that. But on the contrary, at least in my country, we are able to in Europe we are able to give these patients bevacizumab in the time of relapse, if in that case, if they are bev naive. If they have received PARP before and they go to platinum resistant setting, then you still have bevacizumab. So you will get both drugs for these patients. So I would be more prone to, if I have a possibility to reimburse, I would be more prone to suggest PARP inhibitor, niraparib in this case, and save bevacizumab for the relapse.
Thank you so much, Lyndsay. That was great. Anyway, now we're going to hear how to treat these patients from Ritu. She's going to talk about upfront treatment of advanced ovarian cancer.
Well, thank you for having me. I'm sorry, my voice is getting a little scratchy for some reason, but I feel fine. Sorry. But I'm going to talk about upfront ovarian cancer. I'm going to try to be really quick, really just focusing on genetic testing and tumor biomarker testing, focusing on the BRCA and then the HRD testing, and then really quickly reviewing frontline treatment options, which you heard a little bit about already. And so, ovarian cancer statistics, just since I'm presenting frontline, this is incidence is decreasing and our survival is getting better. I was looking back when I was first starting out as a faculty member, 5-year survival was like 30%. And so we've really made some great strides, but there's still a lot of room to improve. But I always just like to highlight where we've come. And you heard about the genetic testing. We had some questions about it from the cases. Almost every governing body I think every governing body that weighs in on ovarian cancer really advocates for genetic testing. And I think the point of cascade testing that Lyndsay brought up is really important. It's hard to take that on, but just to remind the patient to have all family members tested. And here are just the guidelines from patients for testing for at least BRCA, but considering testing for mismatch repair genes and other high-risk gene mutations as well. Now, ovarian cancer is a really complicated tumor where there's lots of mutations. And so along with BRCA1 and 2, which is probably in about 20 to 25% of cases, we actually know that the tumors may actually harbor mutations as well that may not be a germline mutation. So I'll refer to these as tumor testing or somatic mutations. And you can see that even without a germline testing, you may actually have BRCA somatic mutations in a small percentage of cases. And then what we refer to as HR or homologous recombination deficient findings as well. And they're listed here. And when you look at all of these together, it comprises about 50% of ovarian cancer cases. So it is actually pretty prevalent. You can see that there's some other mutations as well. And just because we have targeted therapies for mismatch repair proteins, I think it's always important to kind of get a full picture and look at everything. Once again, with tumor testing, I think we get a little bit, terminology changes, we, find new things out. So I think it's just important to keep up with this. And this is I'm going to thank Angeles Secord because I actually took a lot of these slides from her. So I'm appreciative of that. But just to show that, we use the term HRD for tumor testing, and then there's homologous recombination repair genes. And these are actually not interchangeable. And you can see from these survival curves that there are some differences when you look at the same tumor samples, but look at their survival outcomes based on their mutation status, tumor mutation status. And you can see that this was from the Paolo-1 study, which I'm going to talk about. But you can see that there are some differences here. So these are not exchangeable terms. So the ovarian cancer landscape has really changed. You know, I finished my residency in 2005, and chemotherapy was all that we really had. In 2011 is when we had bevacizumab study report out, and I'm going to talk about 218 a little bit. It had a PFS benefit, but we didn't really see an overall survival benefit. And I would say the uptake of it was a little inconsistent just based on that. And then in 2018, the game kind of changed a little bit, specifically for the BRCA mutation carriers, and that was with the addition of PARP inhibitors. And then in 2019 and beyond, even to this day, we're seeing this explosion of kind of different ways of looking at it, different, different agents, and then different combinations, which I'm going to briefly go over. So I'm going to start with frontline bevacizumab. So like I said, this has been like around for 13 years now, which is pretty daunting to me that I'm getting so old so fast. But we saw significant improvements in progression-free survival when it was added to chemotherapy and then followed by maintenance chemotherapy. ICON-7 was a study done in Europe that looked at the same kind of regimen, a little bit lower dosing, a little bit different patient profiles, but kind of the same benefit was seen in that PFS population. And then I'm not going to go over this too much because I want to save some time for discussion, but Solo-1, olaparib, was the first PARP trial that came out. And this was looking at patients who had BRCA mutations, mostly germline, but there were a couple patients who had somatic mutations. And it randomized these patients to after chemotherapy to olaparib versus placebo. And these survival curves speak for themselves. So you can see, you know, the PFS and the OS, clearly a benefit in those patients who had olaparib. And this became kind of standard of care immediately. PRIMA is another study that looked at the similar thing, and these studies are not meant to be comparative because of kind of the risk profile of the patients, if you will, are a little bit different. But PRIMA looked at all comers, and it randomized patients to niraparib versus placebo following the chemotherapy with platinum-based regimen. And this actually kind of stratified patients to those with HRD deficient tumors, and they looked at BRCA mutation and those without BRCA mutations, and then the overall population. And so this was the first study that actually included those patients who were not BRCA mutation. And you can see the homologous recombination deficient groups on the left side of the screen. These are with or without a BRCA mutation, and clearly a notable benefit with the addition of niraparib following chemotherapy when compared to placebo, with really impressive hazard ratios of 0.4 and 0.5. It's not a statistical endpoint, but the HR proficient or HRD test negative group, there was also shown to have a benefit in this analysis. And you can see the hazard ratio of 0.68. So definitely a less, like a muted benefit, if you will, but still a benefit that I think kind of warrants that discussion about do we use it in all comers. Here's the updated analysis, and I won't belabor this, but kind of re-shows that this trend is continuing. We are looking for the updated overall survival data that might put a wrinkle in things. Paolo-1 is another trial that kind of looked at the same thing, but instead of just looking at olaparib, it looked at the combination of olaparib and bev. The only difference with this one was the control arm also got bevacizumab. So there was maintenance in both arms. Patients must have received bevacizumab with the chemotherapy, so a little bit of a twist on the prior studies. And patients were allowed all comers. And here you can see the results, HRD positive with the BRCA mutation, HRD positive without the BRCA mutation, clearly a benefit with the addition of PARP, olaparib, to the bevacizumab when compared to placebo and bevacizumab. So here, all patients got a maintenance regimen. The HRD test negative group, though, really didn't have a signal here. And so this was kind of approved in those HRD positive or BRCA mutation carrier groups, not the HRD negative. And then here was the updated survival PFS and OS that was just presented. And you can see here, once again, that we're continuing to see this trend. And even in overall survival, you can continue to see that there's a difference between these groups in the HRD positive with or without the BRCA mutation. Same concept, niraparib and bevacizumab was studied. This is a single-arm study. So this is just something just for your review, not something that's really has a label yet. I have less than a minute, so I'm going to go faster. And then this was presented a couple of years ago at ASCO, Athena-Mana, which is looking at rucaparib. And this was predominantly a non-BRCA mutation group just because the other studies had resulted. But clearly you can see that there's a benefit. And this is the intention to treat population, the greater benefit seen in the HRD population. Another study, this is even more of a twist. So DUO-O, this is looking at chemotherapy with bevacizumab with the addition of IO therapy now, durvalumab, or the addition of with IO therapy, and then followed by bevacizumab, durvalumab, and olaparib. A really complicated study. And there were some differences seen here, but the study didn't have, I think many of us would kind of argue that the control arm here was a little bit less than desired. Olaparib and bevacizumab wasn't used as a control arm, and there was no olaparib only arm, so there's a little bit of discrepancy. But the median PFS in the HRD population in this trial was 45 months, and that's the longest reported to date. So I think it's really impressive, and we're shifting the needle in the right direction. And then here's the interim survival that was just presented at this year's meeting, which kind of just shows that the overall survival, really we're kind of seeing less of a difference here, so I think we still need to explore what the role of this regimen is. And then lastly, future directions. PARP inhibitors, bevacizumab, and checkpoint inhibitors are continuing to be explored. So these are just trials that you're going to see in the future. I'm a little pessimistic about IO therapy and ovarian cancer, but I'm curious to see what my colleagues think. So be on the lookout for these. You're going to see these in the near future.
Thank you so much. So we have about a minute left. I want to bring up something really important. You did a great job reviewing all the efficacy data within 8 minutes and how many studies, but we really didn't have time to touch on toxicity. And we had a great question from one of our viewers that asked about bevacizumab. So Brian, when somebody has proteinuria on bevacizumab, the question is, do you suspend treatment definitely? And what is your response to that?
Yeah, that's a great question. I used to worry about proteinuria all the time. To be honest with you, I just don't worry about it so much. So, if it was super high, 4+ or something that I'm really overly concerned about, I would look into it a little further. But I think I talked about earlier the things I look for to contraindicate bevacizumab. Proteinuria is not on my high on my list much anymore.
Yeah, I think if somebody does develop proteinuria, though, this is moderated. This is so bizarre to be the moderator, and also been on faculty before as a panelist. Is really getting a 24-hour urine if it's 2+, and if it's greater than 2, then I'll stop. But it's very rare. I've had 2 patients in the last 13+ years that have had to stop because of proteinuria. But you do need to watch for clinical stigmata of proteinuria. All right, that was fantastic. Priya is going to come up next and present the case as we move on to Module 2.
Okay, so my patient is a 49-year-old female. She presented last year with abdominal pain, distension. She had ascites. CT showed large volume ascites. There were scattered mesenteric edema, peritoneal nodularity, and a 3.6 centimeter left ovarian mass. It actually took a while to get a diagnosis, but eventually she had, when she came to me, she had a peritoneal biopsy as well as paracentesis, and pathology was high-grade serous ovarian cancer. She is BRCA2 germline positive. So I gave her neoadjuvant carboplatin, paclitaxel, bevacizumab, 3 cycles, followed by interval hysterectomy, bilateral self-oophorectomy, debulking, and she only had 0.4 centimeter residual tumor in the left ovary. There was extensive treatment effect. She then completed 3 additional cycles post-op and started on maintenance bevacizumab with olaparib. Olaparib was started barely 3 months ago. She's had severe tolerability issues. I've given plenty of olaparib. I would say this was probably the most difficult, in particular being severely anemic. She had a normal hemoglobin to begin with and dropped her hemoglobin after the first month from 11.5 down to 8.2. I dose reduced her from 300 milligram twice a day to 250 milligram twice a day when that happened, and she promptly dropped her hemoglobin the subsequent month to 6.5 grams, needing blood transfusion. So I have not started her back on olaparib. She is mildly leukopenic, mildly thrombocytopenic as well. So my questions to the faculty, would you make any changes in your neoadjuvant approach? Really struggled with her PARP inhibitor. That all said, have you noticed any differences between the 3 PARP inhibitors as far as anemia? And so let's say she comes back and I put her back on olaparib and she promptly drops back again. Would you switch her to a different PARP? If so, which one? Would love to see what your experience has been.
Yeah, so I think let's go. I love your question about the neoadjuvant approach because that's a very important decision process. Ritu, what are your considerations that you take into play when you're thinking about primary debulking surgery versus neoadjuvant?
So I think if I feel like I cannot completely resect all the disease, we used to have optimal as a definition. I think actually complete resection should be our goal. I will actually recommend neoadjuvant approach. And I think one of the things we can be fooled by, you mentioned this patient had ascites, and sometimes that's reflective of carcinomatosis. And so, if I'm like on the fence, there's not a lot of disease on the CT scan, putting in a scope or doing a small mini lap. But I think this was a totally reasonable approach here in this case where the patient had ascites, peritoneal nodularity, carcinomatosis. I think the one thing that I wasn't clear on, we usually hold the bevacizumab right before surgery, so hopefully it was just 2 cycles, because that can hinder wound healing like we heard about in the first case. But I think the approach was very, very sound, and just ensuring that she has a good response before doing surgery.
And then regarding the PARP inhibitor questions, those can be really challenging clinically. Mansoor, what were your thoughts about monitoring and mitigating side effects?
So first of all, I would like to say that please do not start PARP inhibitor early after chemotherapy. We try to keep them off treatment up to 6 weeks before we start. So give bone marrow a chance. That will help a lot. We never start at 3 weeks. 4 weeks is the absolute minimum. That may help you with some of these issues in the long run. So that would be a very good take-home message. It's very, I have treated patients, enormous number of patients with PARP inhibitors. It's very rare that we have to switch because of the toxicity. I have only 2 patients. One was switched from niraparib to olaparib, the other way around. So there are only 2 patients. Otherwise, we could manage these toxicities very well. But please do not start treatment early. You will get this heme toxicity.
Yeah.
Great points. And also, workup for anemia. Flor, you wanted to say something?
I think I was exactly going to say that. Workup for anemia, but I'm hearing also that she had some issues with her platelets and with anemia. I think when we start seeing those things, and in this GBRCA, germline BRCA mutated patient also, we have to think about AML, bone marrow, what's wrong with her, not with her, but with her bone marrow, that it's already so suppressed fairly early on. So if she's not recovering, in case of your patient, when you already have done 1 or 2 dose reductions and you're holding and she's not fully recovering in a few weeks, then absolutely I would refer to hematologists also just to consider bone marrow punction, because if all looks good, you can feel... Which is you, perfect. But yes, then you can feel comfortable that you can continue treating her, whereas otherwise you want to absolutely keep her off and just keep her on the bev.
Yes. No, she's had a complete workup for other causes, and actually had a fairly long interval with a healthy count before starting her olaparib. So with that in mind, considering that these medications can cause MDS, AML, is there, niraparib is for 3 years, the other 2 are for 2 years. Would you say swap her if you had chosen niraparib down to olaparib, or do you cut down your niraparib to 2 years because that's what the other 2 PARP inhibitors are?
Anybody want to take that one on with 0 seconds left?
Yeah, that's similar to Mansoor. I rarely change patients over. I think if I have the few patients have had some problems with platelets on niraparib, I may change them to olaparib. One of the things I like with GI toxicity, I may change from olaparib to niraparib simply for the daily dosing as opposed to the twice-a-day dosing. But overall, I think we look out for everything that's mentioned, but we're able to get the patients through it with dose reduction.
All right, great points. Thank you so much, Priya. All right, Lyndsay, you have another case for us. And, I wanted to get to the immunotherapy question. Maybe we'll have time at the end. So, Lyndsay, thank you for presenting this case.
Absolutely. This is actually a rather straightforward case, you would think, on the surface. But a 55-year-old who presented initially with her ovarian cancer diagnosis, she also underwent an upfront cytoreduction to no gross residual and then completed 6 cycles of carboplatin and paclitaxel. And she subsequently had a platinum-sensitive recurrence. She had not ever received a prior PARP inhibitor. And then she had testing which revealed somatic BRCA2 mutation. So she was treated with carboplatin and paclitaxel in the setting of her recurrence for 6 cycles. She did very well. She had a complete response on imaging, and she was subsequently started on olaparib maintenance. She's doing very well and hasn't had any issues with toxicities. But my question for you is, in the setting of a platinum-sensitive recurrence, obviously those trials were designed for essentially indefinite maintenance. I'm curious if you guys are treating indefinitely or if you are putting a stop on it.
I'm going to just put this at the faculty. So raise the hands, faculty members, if you treat indefinitely until progression.
We can,
Nobody's
it's not
raising
black
their
and white.
hand. Look at that.
It's not black and white.
Audience, how many of you are treating indefinitely until progression?
We
All
may.
right. All right, and how many are stopping at 2 years? Anybody? Oh, okay. What are you guys just like saying? We'll just wait till the next study comes out and we'll figure it out then?
No, but if I may comment, I think it's a very important question. 8% risk of MDS-AML in this population. We discuss with patient. I discuss with patient at 3 years, 4 years, 5 years. It's almost impossible to convince the patient to stop the treatment because they say that I had only short treatment-free interval and now I'm treatment-free on this drug. Why you want to stop it? Yeah. So it is not easy, although we try our best. We cannot, and the approval is for until progression of disease. So it's a very difficult question.
Yeah,
I think it also depends on,
Go ahead, no, absolutely.
I think it also depends on what the patient's disease status is. If she has disease, it's stable. I'm usually kind of a little bit less, I'm more likely to keep them on the PARP just because I think it's probably maintaining it, doing what it's actually supposed to do. If they have a complete response, then I might be like, hey, now we need to balance the side effects or the potential adverse events with the benefits.
And then, Lyndsay, the next part of your question here is really interesting. So are you suggesting that she's on it till disease progression, then she experiences, at that time, what would you treat with, right?
Correct, yes. If
All
she
right.
has another platinum-sensitive recurrence while she is on her PARP maintenance, what is your preference for treatment in that setting?
All right, Brian.
Yeah, I'm platinum sensitive. I like to keep platinum as long as I can. So I'd choose a platinum doublet, go from there. I think there's a good chance of responding.
And she's also Bev naive, right?
Mm-hmm. Yeah.
I will add Bev.
Yeah, I would agree.
All right, anybody else thoughts?
No.
Okay. All right, a few more questions here, Lyndsay.
Yes, obviously we have some interesting clinical trials that are currently ongoing, specifically one looking at mirvetuximab in maintenance along with bevacizumab. I'm curious about the faculty's experience with patients on that trial, or if anyone is considering, how they're going to incorporate this in their strategies in terms of timing of that particular drug.
Flora, you want to take that one on?
Yeah, this patient has, for now, we have the, if it's a platinum-resistant ovarian cancer, we have mirvetuximab, and the patient is folate receptor alpha positive, greater than 75%. We have the data in that, and I think yes, we have a lot of experience with it. Very effective drug, and overall quite well tolerated. There's some data combining it with bevacizumab that we'll talk about. But absolutely, this is a patient that you want to test early for folate receptor alpha. If she gets in that situation, she don't have to wait before you can counsel her about her options. So earlier on testing, I think, is the other critical portion.
All right, so what about platinum-sensitive disease? Would anybody utilize mirvetuximab with bevacizumab?
On trial, yes. We have the Gloriosa trial for platinum-sensitive for the Gloriosa trial, but using that as a maintenance, I don't think we're quite there yet until we have those trial data for when that's bevacizumab.
Any other thoughts?
Yeah, we have a trial of carboplatin and mirvetuximab, so for platinum-sensitive.
Yeah.
We've definitely seen a little bit more toxicities. It's definitely some challenging, particularly in the hematologic, but I'm really excited about some of the opportunities. We hit in platinum-resistant disease, which is so rare. So I think moving it up and really seeing if it can really make a difference is important.
And we have 45 seconds, Mansoor.
Use your best cannons first. She's PARP naive. She's Bev naive. And Mirva is approved in the platinum-resistant disease. So make sure that you have used these options before you move to the next one. I agree, check for the testing, do the testing, folate receptor, but use the other drugs first.
So I think there's compendia listed through NCCN, though, regarding the use of mirvetuximab with BEV for patients with platinum-sensitive disease.
It's listed as a treatment option, not as a maintenance option.
Well, I think she was talking about if she progressed.
Oh, if she progressed,
right? Yeah, she progressed. All right, so we're going to get to that, another really novel drug that you mentioned there that targets the CDH. So let's move on to this, Flor. You're going to give us some important data that will inform us how to treat those patients.
All right, 8 minutes, and there's a lot more to talk about. So we'll talk a little bit about the updates in PARP inhibitors, PARP after PARP. We'll talk about mirvetuximab soravtansine, and some of the RDXD data. So 2022, dear healthcare provider, we got way too many letters this year, and it was a sad year. We got all these letters, and they just kept coming, and the letters kept coming and coming with taking away, bringing up information about overall survival and taking away the indications for treatment, but then later on restricting it for the platinum-sensitive maintenance situation. And here's where that came from. So this is from for the treatment of platinum-sensitive ovarian cancer. So there were a couple of these different trials. And so Ariel 4 was done in BRCA-mutated patients. They were given rucaparib versus chemotherapy. And these patients had, there were patients in that trial that were platinum-resistant, partially platinum-sensitive, and platinum-sensitive. But in the intent to treat population, when they looked at overall survival, which is listed here in the table, there was a numerical difference, 19 versus 25 months, in favor of the chemotherapy arm, with the hazard ratios of 1.3. And then when they looked at Solo 3, which is also in the BRCA mutated population, olaparib versus chemotherapy, again, when you saw in the population that had more than 3 or more prior lines, numerically better survival in the chemotherapy population, not statistically significant, and none of these were primary endpoint or powered for this. So based on some of this data that came out with worries about overall survival in these data, is that the FDA started taking the treatment indication away. But it's hard for platinum-sensitive patients. I think we all have these patients that were platinum-sensitive, and they'd say, I don't want to do chemotherapy again. And look at on the right-hand side, this is from the Ariel 4 overall survival data. We saw a hazard ratio with rucaparib versus chemotherapy of 0.5, PFS 2, 0.73, and then the 29 versus 27 months for overall survival. So it can still be an option, but it has become very limited. In the maintenance situation, after platinum-based chemotherapy for platinum-sensitive recurrence, similarly, the FDA started looking at overall survival. Again, there was a non-analytical endpoint, not powered to do this. And the difference is here, I'm going to go back one, if I can. Looking at the numbers, we see a difference, numerical difference, slight differences here, 31 versus 34, 35 versus 41, hazard ratios that are crossing 1 and over 1, and concern about overall survival if you give PARP inhibitors in this setting. So we don't have this opportunity anymore for non-GBRCA. Fortunately, we didn't see this similar trend in the GBRCA population where we still have these available. But in the non-GBRCA, even for those patients that are HRD positive, based on all these differences here, or not statistically different, just a numerical difference, we've been very restricted. And so this is what we have left for our PARP inhibitor indications. In the first line, as was mentioned, we have germline somatic for olaparib, all comers for niraparib, olaparib bevacizumab for HRD positive, but in the second line, it's been restricted to germline and somatic BRCA mutated patients. And for the treatment of recurrence, even for platinum-sensitive recurrence, we don't have this anymore. How about PARP after PARP? This is a different study. This is a study that was done in the era of platinum-sensitive maintenance, and that's where the majority of these patients received treatment with a PARP inhibitor. For this trial, they had to have one course of prior PARP maintenance, CR or PR to most recent platinum-sensitive or platinum regimen, or any after surgery, and then they had to have a mutated or a non-mutated status, but the status had to be known. They were randomized to, again, receiving a PARP inhibitor for the second time now, olaparib versus placebo, with the primary endpoint was investigator assessed. And I want to go back one here. I want to point out that 85% of the patients had more than 3 prior platinum lines. 20 to 35% had a CR. So this was a very difficult to treat population. And as you see, 7 and 14% had first-line maintenance. So this was mostly all second-line maintenance. You still see those differences here, and the median progression-free survival was short, 4.1 versus 2.8 in a BRCA-mutated population, but it has a ratio of 0.57, so there is a decrease in the risk of progression. And so this brought about, with these small differences, should we be giving PARP inhibitors if they've previously received PARP already? But you see most of this drop-off in the first 3 to 4 months. So you know pretty quickly which patients are going to, where your patients are going to be. And so it's hard. I think if you have a recurrence and this is what you're going to do without a PARP inhibitor, even if you've had a prior PARP, or you want to be in a red curve on a blue curve, there is still a separation of those curves without a detriment to your overall survival. So I think it's not excluded. The hard part here is that we don't really know which patients are on that blue line, and that's what we have to figure out more. Were those the patients that never progressed on it and had a PARP? To Brian's point earlier, they were the ones who had finished their course or stopped their PARP and then progressed later, or were they progression on PARP? So there's still some room. I have 2 minutes to go. So mirvetuximab, real fast, folate receptor alpha targeting ADC. So this is a humanized monoclonal antibody binding to folate receptor alpha. The payload is a DM4 maytansinoid, so a potent tubulin targeting agent. The MIRASOL trial was the confirmatory phase 3 randomized controlled trial. This compared mirvetuximab single agent versus standard of care chemotherapy with doxorubicin or weekly paclitaxel. 453 platinum-resistant ovarian cancer patients enrolled. They have to have folate receptor alpha high with 1 to 3 prior lines. Prior BEV, prior PARP was allowed. And objective response rates here, 42% versus 16%, with a duration of response 6.7 versus 4.7. And here's where we see the progression-free survival and overall survival curves with a nice improvement, both in progression-free survival, but more importantly, we see for the first time in platinum-resistant ovarian cancer that there's an overall survival benefit also with this single-agent therapy. Overall, pretty well tolerated. Yes, we do see some blurred vision, keratopathy, very little myelosuppression compared to chemotherapy, diarrhea, nausea, but overall very manageable side effects with especially using eye drops. So based on this, the FDA approved this full approval just recently in March. For the sake of time, I'm going to skip over this. You'll have this, but this is mirvetuximab with bevacizumab is an option for those patients who have folate receptor alpha expression lower than 75%, but more than 25%, and also appears to be very effective. Lastly, I can't pronounce it, RDXD, monotherapy in patients with previously treated ovarian cancer. So this is a humanized anti-claudin CDH6 antibody. CDH6 is a cadherin antibody, so humanized cadherin antibody 6. Expression is present in 65 to 85% of patients with ovarian cancer. And so Dr. Moore did this, led this phase 1 first-in-human study. Patients were treated with RDXD, 4.8 to 6.4 milligrams per kilogram, IV every 3 weeks. They had 45 patients. Median prior lines of therapy was 4. So very heavily pretreated, all platinum-resistant, prior BEV, prior PARP. And very exciting results here. Almost 50% objective response rate in this population. population with a disease control rate of 97%. Median progression-free survival was 8.1%, and there did not appear to be a correlation between the CDH6 expression and response. And now this is in a phase 3 trial comparing it to standard of care therapy. Safety profile, no new surprising findings here. Low rate of alopecia, I'll point out. So overall, we have an increased use. We have to use our PARP inhibitors in the first line. We have limited indications for PARP inhibitors in the second line, but consider for patients who have no prior progression on PARP and a long PARP-free interval. There's many exciting options for platinum-resistant ovarian cancer with antibody-drug conjugates, different targets, different payloads. Unfortunately, we haven't been as successful with immunotherapy, but some novel immunotherapy strategies are under development.
Thank you so much, Flora. In the interest of time, we have to go to our next module. So Priya will come up and present.
All right, so for this case, for endometrial cancer, I want you guys to go back to 2017, because we did not have immunotherapy quite approved in the first-line setting. So she's a 63-year-old female diagnosed initially with stage 1, grade 1 endometrial cancer. She had her surgery back in 2015. Did not have adjuvant radiation therapy. I met her 2 years later in 2017 when she presented with abdominal pain. She had a very large 15 by 12 centimeter mass in her central pelvis, additional smaller masses in left pelvis, pelvic lymphadenopathy. This was not amenable to resection. Biopsy confirmed recurrent endometrioid subtype endometrial cancer. She was MSI high. So at that time, in 2017, I treated her with carboplatin, paclitaxel, and bevacizumab for 6 cycles. She had a partial response. She underwent intimal debulking. She had residual pelvic mass with endometrioid features. There was focal squamous differentiations, extensive necrosis. A subsequent PET-CT about 4 weeks later confirmed presence of mass in the vaginal cuff and upper vagina, some pelvic lymphadenopathy. So at this point, her disease was confined to the vaginal cuff area. With that in mind, and again in collaboration with her GYN oncologist, we decided to give her weekly cisplatin with radiation therapy for 6 weeks. She also had vaginal brachytherapy. She had significant neuropathy with cisplatin. This is her second go-round with platinums, and did not have a good response. She basically was a partial response. So subsequently, again, in collaboration with the GYN oncologist, we decided to resume carboplatin, paclitaxel, bevacizumab. And she had good response to it, partial response, but better than the radiation therapy. However, developed other toxicities, including bleeding. She also developed a rectovaginal fistula. There was a new soft tissue mass adjacent to the sigmoid colon, at which point we had to stop treatment with bevacizumab, essentially with her chemotherapy. The GYN oncologist had a long discussion with her at that point, discussing anything from pelvic exenteration to consideration of switching treatment with liposomal doxorubicin versus her tumor being MSI high, again back in 2018, to consider switching her to pembrolizumab. She chose pembrolizumab and had an amazing response to it. She tolerated it extremely well, except for minimal colitis, which is easily treated with steroids. She also had acute nephritis. I had to bring her into office multiple times for hydration. And she also had hypothyroidism, which was easily managed. PET-CT, after 7 months of treatment with single-agent pembrolizumab, she had no evidence of disease, and 3 years out now, she is with no evidence of disease. I have some pictures to follow. That's my patient. She has graciously allowed me to share these pictures with you all at this meeting. That's her with her husband and her grandchildren. And the next picture is my wonderful team. That's my nurse practitioner, medical student. We had great pleasure taking care of her, and that was the last day of her treatment. So with that in mind now, coming back to 2024, we have multiple choices of immunotherapy to choose from. What's interesting is pembrolizumab is not on official FDA label in combination with chemotherapy. It's approved in the recurrent setting as a single agent. On the other hand, dostarlimab has an official label. They both are allowed, so to speak, on NCCN guidelines along with chemotherapy. What's also interesting is pembrolizumab is 2 years or until progression. Dostarlimab is 3 years or until progression. So with all those nuances, wanted to see your thoughts as far as choosing between pembro and dostarlimab as far as duration of treatment, maybe some efficacy differences or adverse event profile difference that you may have noticed between the two agents.
Mansoor.
So, thank you. Your patient had in 2015 early stage disease, no treatment, and that remains the same today. In 2017, when she got that first relapse, there we discussed these options, and absolutely she should receive chemotherapy plus immune checkpoint inhibitor. Which immune checkpoint inhibitor you will use, it's up to you. They have the PD-1s, both PD-1s have shown a clear benefit. One is dostarlimab, one is pembrolizumab, and she's MSI high. She has a great chance of complete remission already there, and she has a great chance of keeping that remission up to 50% of the population. 60% of the population may not relapse. And the hazard ratio for overall survival has increased by 0.32 hazard ratio. That means 68% risk reduction. So there's no question that this patient must receive chemotherapy with one of the PD-1s, but you have available.
Well, and thank you so much for that.
Would you stop dostarlimab at 2 years as opposed to dragging along? Would you stop dostarlimab for 2 years, which is sort of what we do for all immunotherapies across the board?
That's another very important question. Now we have 3 options with the trials we have done. Either you give 2 years or 3 years or until progression of disease. I think this is the next question we have to answer in the trial basis, in real-world evidence trials. So we have to answer that. In the DMMR population, I believe we can go even less than 2 years. If you look at the Kaplan-Meier curves after 1 year, you hardly see any relapses. So the question is, do you need such a long treatment? So I cannot answer you by the evidence, but I would like to see a trial cutting even shorter.
Yeah. Well, thank you so much for bringing that case to us, and we're so happy your patient's doing well. All right, Lyndsay's going to present another case. I think there's so much interest in de-escalation. Is it 2 years or 1 year versus 3 years? So Lyndsay?
Yes. Yeah, so this is a lovely 73-year-old who presented with postmenopausal bleeding, and a biopsy showed a carcinosarcoma. She did also undergo surgery and was noted to have disease in the omentum. So this was consistent with stage 4 disease. She had somatic testing performed, which did show that this was actually a MSI high / deficient mismatch repair tumor. So following her surgery, she received adjuvant therapy with carboplatin, paclitaxel, and dostarlimab, and is currently on dostarlimab maintenance. She's doing very well. She is without any evidence of disease at this time, and thankfully has not had any significant dose-limiting toxicities, but did have some hypothyroidism that has been managed with levothyroxine. So I am curious to speak with the panel about how they are kind of advancing their discussions with patients in terms of incorporation of immunotherapy. And I think I'm especially interested if anyone is leapfrogging, though we don't have the data yet, in C93, and considering just dropping the chemotherapy in these patients and using only IO.
So these are excellent questions, and I'm just looking at our faculty panel here, and you have the Ruby PI, you have the C93 PI, you have the GY020 PI, and then how many, you've been the PI for several IO studies in cervical cancer as well, right, Ritu? So I cannot imagine a better group of people to answer these questions. So Brian, what's your thoughts?
No, thank you very much. Let's just quickly go through this. So carcinosarcomas were included in Ruby trial. Originally that we discussed that, and really based on the great work of Matt Powell, he showed that if you treat carcinosarcs the same way as you do all endometrial cancers, it's the right treatment and they behave the same. So yes, I would definitely give a DMMR patient, even with carcinosarcomas, immunotherapy. And it's the beauty of the 4 molecular subclassifications. We're taking out histology. Some histology are more likely in some classifications than others, but we treat by them. And then, importantly, the question of C93, and for those of you who don't know, is C93 trial. It's close to accrual. We're waiting for the results. It's basically using immunotherapy alone versus chemotherapy alone for the first-line management of advanced recurrent measurable endometrial cancers, pembrolizumab versus carboplatin and paclitaxel. We found in colon cancer that it works. I would say right now it's an interesting question. I hope that it's a positive trial, but until we have the results of that trial, we need to give chemotherapy with the immunotherapy, followed by the immunotherapy. So, but if it does work, we're going to get rid of chemotherapy in a large part of our patients, which is
right, Mansoor's
cool.
ready.
The question is not it's going to be positive. It will be positive. The question is how positive.
Right.
Because you have a Ruby trial which has shown overall survival of hazard ratio 0.32. And then you have lenvatinib trial, which is also a chemotherapy-free trial. That's chemotherapy, carboplatin, paclitaxel versus pembrolizumab, has shown in the DMMR population progression-free survival with a hazard ratio of 0.61, which is far away from 0.28. So if that is the case, I'm not going to not give chemotherapy to these patients, but let's hope that we get a better results in the 093 to get that. I will just mention one more thing. You said carcinosarcoma, and you also touched on that. It's probably P53 mute patient, and that means this is a double classifier. She's DMMR, P53 mute, and you treat it right, you treat it according to the DMMR.
All right, Lyndsay, you have some more questions for us?
Yes, I think that perhaps one of the most important questions that we have in terms of these patients is the length of treatment. And I know you guys touched on this a little bit, but for someone who has stable disease, are we discontinuing the IO at the 2 or 3 year mark, or are you considering continuing treatment beyond that?
Anyone want to take this one on?
We already discussed that in the
previous. So we did it earlier a little bit. But I think at this point, we didn't really have a firm conclusion. So I think we should try this question you have up here about the POL mutation.
Sure, yes. Are people now utilizing the presence of a POL mutation is in terms of de-escalating therapy? I don't think that that's yet been answered conclusively. So I'm curious if people are doing that ahead of the data.
Ritu, are you doing de-escalation for patients with POL mutations?
Kind of. I think for the high, what we used to call high intermediate risk, if they have a POL mutation, I happen to find it, I actually might not give them additional therapy. Those are probably the only place where I'm really kind of feeling strongly about it, because even in the 2023 FIGO staging, we've downstaged these patients from, if they were stage 2, now they're stage 1A. So I actually feel that's okay, and that's probably where I'm doing it. The patients with advanced disease, like advanced metastatic disease, I'm not quite there yet. So I'm curious to see what others think.
I'm going to launch off of that for a second. So FIGO 2023 staging, how many of you are using the new staging? Raise your hands. Okay, so very few, very few. Some in there, all right. I'm not yet, so we'll see what happens. But fantastic patient discussion. Thank you so much, Lyndsay. And next, Mansoor is going to really illuminate and give us all the right answers with his presentation on first-line therapy for advanced endometrial cancer.
Thank you. I was asked to talk only about immune therapy in first line, so that's I'm going to keep to. And why immune checkpoint inhibitors have shown, in which Brian will show in the second line efficacy, both in the DMMR and also moderate efficacy in the MMR proficient disease. We know that chemotherapy enhances immunogenic cell death, and addition of PARP inhibitors to immune checkpoint inhibitor may further improve outcomes. So that's why we have done the trials answering for these 4 trials don't compare to each other, because they're different populations, different endpoints, but they're trying to answer the same question. If addition of immune checkpoint inhibitors on top of chemotherapy, carboplatin paclitaxel, going to be beneficial? We have 3 trial results already published or presented. The B21 trial is not presented yet, but there was a press release that it's a negative trial. The second question we have asked is, in these 2 trials, that on top of that we are giving patients chemotherapy plus immune checkpoint inhibitors. Can we add PARP inhibitors on it? And I'll try to answer. I'm not going to take the third question we are asking, as we know that we are waiting the data for 2 trials, that can we replace in the DMMR population completely chemotherapy? We won't have data yet, so I'm not going to touch that. So what I'm going to do is not going to trial through trial, because that will take quite a lot of time. I will put them in perspective and see what answers we have received according to this promised molecular classifier, starting with the DMMR and going to the MMRP population. So first question we asked, addition of immune checkpoint inhibitors on top of chemotherapy in the DMMR, is it beneficial? And these are the overall survival curves. And the primary endpoint of Ruby trial was overall survival in intention to treat population. Look at the curve separation. Look at the experimental arm, that if you take the population, US population of 68 years of age women, and look at their healthy women, and look at their their survival curves, you will they will almost overlap this survival curve of these patients. So I believe that we are curing quite many of these patients, and they may die of something else. Look at the hazard ratios. All these, the first 2 trials you see here are PD-1s, the other 2 are PD-L1s. Everything is, this is a very susceptible tumor. All drugs are effective in these patients. When we come to the next question, there was some retrospective small analysis of earlier data showing that maybe there was a difference between response to immune checkpoint inhibitors if there was methylated or mutated. And we saw the GY018 results presented last year at ESMO showing there is no difference. If either patient's tumor is methylated or mutated, you see response. I'm not allowed to show you the Ruby results because of the embargo. You have to come to poster session tomorrow at 9 o'clock to see that. Few hours more. Then the next question is addition of PARP inhibitors. You saw the other trial. In the DMMR population, does it matter? I cannot answer. There are 2 trials. I cannot answer from the Ruby trial yet because we have to do a comparison analysis of Ruby Part 1 experimental arm and a Ruby Part 2 experimental arm. We haven't done that yet. We are still not mature there. But in the Duo-E, you had arm B and C. I know that they were not powered to show difference between each other. But I don't think we have to see this much statistics. If you look at the hazard ratio of B and C, hazard ratio of 0.41 and 0.42, there is no difference. So I don't see that PARP inhibitors are adding anything in the DMMR population, so save these patients from proper PARP inhibitors. So if I try to summarize that, substantial, unprecedented benefit of immune checkpoint inhibitor addition to chemotherapy in the DMMR population. We don't see any benefit of addition of PARP inhibitor, and mutational and methylation makes no difference. These all patients are responding very well. Let's go to the other side where you see not that huge difference. Here are the overall survival curves. Again, the mature data is now only from the Ruby trial, where you have seen median 7 months overall survival benefit in this population in the mismatch repair proficient disease with a hazard ratio of 0.79. And there is modest, the energy trial is not mature either. So you see the difference, but it is getting modest. So the question is, again, the next question, Is it beneficial to add PARP inhibitor here? I cannot answer that question from Ruby, but from DUO-E, although you can see by visually and the hazard ratio, there is a difference of hazard ratio 0.54 or 0.77. So it seems like this is the population which is benefiting of addition of PARP inhibitor on top of immune checkpoint inhibitor. But remember, we saw 7 months median overall survival benefit in the Ruby trial in the mismatch repair-deficient disease. So if you're adding another fourth drug, PARP inhibitor, and adding more toxicity, you have to do much better than 7 months in order to take them in the clinic. So we have to see the results. The next question would be, which MMR proficient patients will benefit from immune checkpoint inhibitors plus chemotherapy plus minus PARP inhibitors? We need data from other trials, but we have already data from Ruby Part 1 and Ruby Part 2. I have taken only the MMRP population. Here you can see that very surprisingly, the P53 mute carcinosarcoma was one of your patient here, showing a very interesting benefit. Overall survival hazard ratio of 0.41. And when you are adding on top of that in the Ruby Part 2 PARP inhibitor, although numbers are small, hazard ratio is 0.29. So it seems like that is the population. These are the patients who are benefiting the most. This is retrospective analysis. This is hypothesis generating. If other trials show the same, all 4 trials, then it becomes a reality, then it becomes right. When it comes to the NSMP population, these are the non-DMMR P53 wild-type population. We don't see that benefit. We still have to see that benefit in that population. So potential benefit seen in the P53 mute group. So when we go to the other biomarkers like PD-L1, we don't see either in the DUO-E trial or in the Ruby trial that PD-L1 is doing anything good. So it's the MMR testing is the right one. When we look at the HRR analysis in the DUO-E trial, you see some benefit. We had very few numbers in Part 2, so we don't have that data available in this case. When it comes to the mutational burden, otherwise, we don't see much difference here. So if we summarize that part, potential benefit in patients with MMRP tumors with immune checkpoint inhibitors. Now we have overall survival benefit as well available in Ruby. And I just wrote one poly. I haven't shown these patients never progress. They never die. So I don't think I have to add immune checkpoint inhibitor there. There is no need. I completely agree that we in the stage 4 disease or first relapse, we cannot, the numbers are small to say that we stop treatment, so we have to treat these patients. When it comes to the poly wild type in the P53 abnormal populations, potential clinical benefit seen in the dostarlimab plus minus PARP, and in NSMP population, we don't know. We have to answer that question. We haven't seen that benefit until now, so we have to see other trials. And remember, if you're adding PARP inhibitors, you are adding more toxicity. So you really need to see a substantial benefit on top of giving immune checkpoint inhibitors before we take that in the clinic. So key takeaways, you have to do molecular classification up front. We are changing our guidelines in Europe, the ASCO-ESP. We are only going to refer to the molecular classification and to FIGO 2023. We have still a lot of questions, but we know that now immune checkpoint inhibitor plus chemotherapy is the new standard of care for patients with advanced recurrent endometrial cancer. But we have to answer all these questions. There are more questions than answers now. We are just at the beginning of the whole thing.
But still, we've come such a long way since 2023 when that was presented and it changed the standard of care. So thank you so much for that great presentation. Priya, you're going to start the next module for us with your case presentation.
Yes, this is not as, what should I say, happy ending as the other patient. It's a very sad story, and I would love your input on this. I really struggle with this patient. So she's a serous endometrial cancer, 60-year-old, had surgery, had adjuvant chemotherapy radiation treatments. 2 years prior, I did not have any details of her records. When I saw her, she presented with abdominal distension, had ascites, she had nodularity in her omentum, and again, she was recurrent serous endometrial adenocarcinoma. Next generation sequencing shows MS stable, HER2 negative, by IHC shows TMB low. So I started her on, she had significant grade 2 neuropathy at baseline, and instead of choosing paclitaxel, I chose carboplatin and docetaxel. After 4 cycles, she had significant worsening of her neuropathy, so I switched her on to lenvatinib pembrolizumab, and literally dragged her on for 7 months on that treatment, hoping for a response. She did not respond to it. She actually had significant toxicity, rash, a lot of fatigue, weight loss. And so I went on to 3rd treatment with carboplatin, liposomal doxorubicin. Again, literally seemed like I was dragging it for as far as I could. After a couple, 3 months, she had progressive disease, and then I just switched her to single-agent Bev, and she had progressive disease and subsequently passed away. So with that history, people with MMR deficient tumors obviously have lots of good choices, but when it comes to MMR proficient tumors, in the recurrent setting, again, considering that this patient had significant neuropathy at baseline, I wanted to give her liposomal doxorubicin off the bat for first-line recurrent disease, but on NCCN it's listed as the second-line treatment. What would you have done in this case with her baseline neuropathy for your first-line choice in the recurrent setting?
Yeah, this is such a hard situation, and I'm so sorry. I know it's always hard whenever we lose a patient. I think this question is really important. Do you want to take this, Ritu?
Yeah, sure. I mean, I agree. These are always challenging questions or situations. I do have a couple of thoughts, though. One, I'm not a big fan of liposomal doxorubicin in this setting. I just don't think it has a role in endometrial cancer, and I'm actually kind of annoyed that it's listed on the NCCN guidelines at all in this disease setting. So I'm going to say that, and I might be standing on an island. I do think that there are some opportunities to think about, she did have neuropathy, and I think docetaxel, we've seen that from ovarian cancer. I think that's a reasonable choice. Gemcitabine has shown some activity as a single agent in endometrial cancer, so I think you could combine it with the platinum. And I think we're going to hear about selinexor, which would be a maintenance option that might be a strategy to consider for these patients moving forward. I would also be curious at what her ER/PR status is, and I think that's a regimen that we don't think about, or therapy or strategy that we don't think about enough. We use it in frontline for fertility-sparing situations, and we use it for palliation, but I actually think there's a good role for it kind of maybe sooner. And so it would be curious to see, because that might be a regimen that is really well tolerated overall.
Go ahead. Oh, well, Flora and Mansoor. Go ahead.
If I may add, we have seen the subgroup analysis of Keynote 775 that the patients who had less number of treatments before, they have a higher responses. We have seen the LEAP-1 trial that the patients who had chemotherapy and after that pembrolizumab in the relapse setting, they were doing better. So I would push these single-agent chemotherapy after pembrolizumab. I will push that treatment as early as possible for her. She has already had chemotherapy, and I don't know what was the situation, if she still will fit for the first-line trials. If not, and she has neuropathy, that would be the right treatment. I don't know.
And I know Flora wants to go, and then Brian, you're after that.
Yeah, this is a patient, I think that you mentioned it's a high-grade, or it's a serous carcinoma. So the hormonal therapy, I agree, we forget easily about it. There's just unfortunately not that many patients with serous carcinoma that are hormone receptor sensitive. So I think you did that well. I kind of agree with you that liposomal doxorubicin, if I go back, I think I have some patients, doxorubicin doesn't work that is not a great response rate, but I have some patients in this situation where it actually worked. So just single agent doxorubicin is still an option. And then, yes, she's HER2 negative, but we now have some clinical trials also that she may be eligible for that target TROP2 or folate receptor alpha For endometrial cancer also, and especially in a serous patient, I would absolutely look hard to see if she could be going on a clinical trial somewhere too.
Brian?
Yeah, I would go quickly because a lot of it's really been said. If you really want to give a chemotherapy, and she deserves a platinum, without giving a taxane, cis-Adria has historically really good response rates. That's where we started to get to where we are now. And it's toxic, but if it's good performance status, I'd consider that. Agree that lenvatinib pembrolizumab in this setting is the right choice. And then after failing lenvatinib pembro, I would go to the control arms of 775, weekly taxane, which you can't give here, or the adriamycin. But we've been fooled to give liposomal doxorubicin to these patients to the point earlier. It really doesn't work as well in endometrial cancer.
All right, Priya, you have a few more questions? We probably have
Just
time
in the
for
last 10 seconds, choice of lenvatinib dosing.
let's just go down here. Brian, what do you start at?
20.
Mansoor?
Well, I start always at 20, but it takes me 2 weeks to come down to 14 or 12. So, but I have learned one should start at 20. I know others do not start at 20. I start at 20, but the hypertension and diarrhea are the two ones which comes within a week or two, and I pause the patient and drop down.
So you start at 20 minus. Go ahead, Flor.
That was a long way. You
I did
just said
20
20.
as well. I mean, there's decent data out there that we should satisfy this, or just all occupy the targets and then come down from there. So
Ritu?
Agree.
Really? Wow.
20.
Brave
How many of you
oncologist.
start at 20? All right,
Yes, I see
14,
you. I see you.
10, 18 and a half. No, that's a trick question. Anyway, let's move on. All right. We have another, Eric is going to give us another case.
All right. This is a 77-year-old, originally diagnosed several years ago, actually 2 years ago, 2.5 years, 3 years ago now, with endometrial cancer, initially treated with a surgery followed by adjuvant carboplatin paclitaxel and vaginal brachytherapy. I encountered her 2 years after that when she developed pulmonary symptoms, and staging showed she had cannonball lung lesions. It was a very, very dramatic PET CT with bone metastases. We biopsied. It was recurrent endometrial cancer. She was microsatellite stable, mismatch repair proficient, PD-L1, CPS 30. Interestingly enough, on NGS, she does have a PIK3CA. I opted to treat her with carboplatin paclitaxel and dostarlimab. She had a very good partial response after 3 cycles and then near complete response after 6 cycles. So I transitioned her to dostarlimab maintenance. She has actually been on maintenance for about 6 months now. I just saw her last week, and now she has a recurrence. Left lower lobe, initially where she had her large burden of disease. She is at the 6-month mark, and I did send for a liquid biopsy. She does not want to go for a repeat biopsy. She declined it, so I sent for a liquid biopsy, and I'll probably re-challenge her with a platinum doublet at this point. I was wondering if there's an input from the panel regarding how they would approach this case.
All right, wonderful. Start with Flor.
Yeah, I think, this is a great, you have a couple options here, and I think you picked a really great one. The chemotherapy with dostarlimab, I think that's excellent. You also had a choice to consider doing lenvatinib with pembrolizumab in this patient who has had previous chemotherapy, also very effective, and we haven't compared those two together yet. But in the LEAP trial, what we talked about a little bit earlier, they saw that those patients that had prior chemotherapy, that there actually was a slight difference there in response in favor of lenvatinib pembrolizumab. So not for the chemotherapy naive patients.
But they were IO naive.
Yes, not for the naive, but for the prior treated. So the other thing that I think in some of these chemo IO situations, sometimes they have a really excellent response and there's one lesion remaining and everything else is gone. In that situation, I also consider using radiation, but if they start having that recurrence already pretty early on, it's tricky. If it really all went away or everything melted away and one is residual, then radiation. So I'd probably not favor that, but always something to keep in mind when you have your patient on IO. You can continue IO, but just spot treat.
Brian?
Yeah, no, a lot of great points. And I agree with localized therapy. If she's a good performance status, isolated recurrence, oftentimes we forget, call up our thoracic surgeon, see if they can take it out. I think this is a good case, maybe even a better case to evaluate hormonal receptor status because if she's, I don't think it said endometrioid or serous, it just said endometrial cancer, but she's endometrioid, this type of course, she may in fact be ER positive. To give her one of those options wouldn't be bad. I've shied away thus far of IO after IO, so I don't. In my practice now, I don't think I would consider Len-Pem on her, but chemotherapeutic options, weekly paclitaxel, or
yeah, there was that study that evaluated, it was a small, very small sample size of patients who they treated with Pemlin after IO and did see some activity.
Yeah,
but it's small.
I think it was a case study. I think it was a
it's
case
very
series,
small,
not a
very
study.
small.
but those were DMMRs. Most of those that responded were DMMRs. This is a PMMR tumor, so they went from the single agent activity, adding lenvatinib to kickstart it.
Let me just start one, but she didn't get rebiopsied. I know it's small numbers, right? But there is some data about rebiopsying these patients, and a small number will have DMMR, MSI-high disease on subsequent biopsy. And I know your patient declined.
So we are doing in a Ruby trial a very good analysis of PFS2, and we are collecting all the data. We don't have enough events. When we have enough events, we will be looking those patients who received IO before and then received pembrolizumab, which we have quite a few. How did it go? We don't have that answer yet, but that would be more structured.
Stay tuned for ASCO next year, right?
Yes.
And you had some more questions for us as well, Eric?
Sure. Let's just jump to the combination question. We just heard about some data regarding combining checkpoint inhibitors with PARP inhibitors. I think there was a summary of that, but I just wanted to hear from the individual faculty here whether they would feel comfortable using it in the absence of kind of finalized data. Would you consider combining a PARP inhibitor with a checkpoint inhibitor? And in what situation would you do it?
Yeah, go ahead, Brian.
Yeah, I would start off. I know Mansoor did a great job with Ruby Part 2, and Shannon Weston did a great job with Katie Moore on Duo E. I think the answer at this point is we have to look at the molecular profiling.
Yeah.
And that's not been available yet. So there is a positive signal. So I think to say it doesn't work, I don't think is fair. And I think to say it works, we don't know which patient it works in. So let's get that data. Let's take our time, purposeful evaluation. There will be patients, but we don't have the answer yet today.
My guess is, if to keep it simple, probably it will be the P53 mute population, because there you see the concentration of HRR population. That's the guess, but we have to, as Brian said, do the molecular classification.
And they tend to be the chemo-resistant population as well, so it kind of makes sense to use some targeted agents.
Thank you so much, Eric. All right, Brian, well, you're going to talk to us about current options for recurrent endometrial cancer.
Great. So I'm here to fill some gaps. We really nice review of what to do in the first-line therapy, but there's some gaps as far as how did we get there? What about the patients that don't get IO in the first line? And then at the end, I'll talk about some future directions. So really, how did we get there? You know, we've talked about this, biomarker selectivity, molecular profiling. Here's data. This is, I'm going to go through dostarlimab data and pembrolizumab data. This is in the previously treated patients, second-line setting. How did we get to see that IO works? In a population, the 46 patients who were DMMR, 46% response rate. In that population, it's clear. If you didn't get IO in the first line, you're DMMR, you have a 46% chance of responding. Remember GOG 209, which was a first-line trial. First line had a 52% response rate. So this number is remarkable, 46%. Biomarker negative, no PMMR, 19%. We need to do better than that. Similarly, in the Keynote 158 data, how did we get in the second-line setting to say that pembrolizumab works? Biomarker positive, MSI-high, 48%. Non-biomarker selected, unselected populations, 11%. So what could we say at this point? In second-line setting, in those patients not pre-treated with IO, DMMR, single-agent IO works. But what about the 2/3 of patients that are PMMR? What do we need to do to make a cold tumor hot? Vicky Macker did great work, first in a lead-in trial and then to this registrational trial. Keynote 775 looked at exactly this, giving pembrolizumab with a tyrosine kinase inhibitor, lenvatinib, after platinum-based chemotherapy or advanced endometrial cancer to see if that, in fact, could make a difference in all patient populations, but specifically in the PMMRs as well. Primary endpoints was PFS by BICR and overall survival. Straightforward design. The control arms are the agents that we talked about. Adriamycin, not liposomal, adriamycin, or paclitaxel with the control arms, compared to lenvatinib and pembrolizumab, PURA 20 milligrams, and that's what they started here. So here's the progression-free survival curves showing in the PMMR on the left, all patients on the right, showing a benefit of the lenvatinib pembrolizumab versus chemotherapy, 6.6 versus 3.8, hazard ratio there of 0.6, and in all patients with a hazard ratio of 0.56. Survival data very similar, good hazard ratio of 0.68, 0.62. And the long-term follow-up, which Vicky presented at ESMO in 2022, similarly, it's consistent. In the PMMR population, overall survival had a hazard ratio of 0.70, and all comer population 0.65. So at this point now, what can we say? Mansoor went through the first line. It works if you use it. Works better, some better than some than others. But in the recurrent setting, DMMR, FDA approval, PMMR, based on this data, FDA approval. It's pretty cool that we could say all women with endometrial cancer deserve immunotherapy at some point in their treatment. That's really cool to say, and that's something we're really proud of. But we also then have to talk about the side effect profile and things like that. So here's a safety profile and some data of pembrolizumab in patients with advanced endometrial cancer. It was really consistent across the board with the monotherapies. The most frequent side effects for pembrolizumab: hypertension, hypothyroidism, diarrhea, nausea, and decreased appetite. The most common grade 3s are shown here. Importantly, any disruption of interruptions of therapy, 69% in patients receiving lenvatinib pembro. Discontinuations in the total population, 14%, 31% decreased lenvatinib, 18% discontinued lenvatinib, 19% discontinued pembrolizumab, leading to dose reduction 66% of the population. So what this taught us, and what we've been really trying to teach not only each other, but our patients especially, is what can we do to help mitigate the side effect profile in order for these patients to get the good drugs that work and improve overall survival. Here's a summary list of those patients treated with lenvatinib and pembro, the side effects and when they occur. You can see here, and I know you have, it's probably easier to read on your screen there, but you see the side effect profile and when they occur. One of the cool things, one of the things we've learned about with immunotherapies, you could sort of time out the side effects when they occur along the course of their treatment. And you could see that here. But the side effect happens. What do we do with the side effects? So I want to first talk about hypertension, and then I'll talk about diarrhea, because these are the two that we see. Hypertension. When do we start treating our patients with lenvatinib? When we decide to give it. Before they get the prescription, I tell them they have to control their blood pressure, they need to see their primary care doctor, do whatever they need to do, because if they're on the borderline of the hypertension before lenvatinib, it's going to get worse. Lenvatinib should be withheld in any instance where participate is at imminent risk for a hypertensive crisis. Those who are on hypertensive medicines sometimes need more than one agent. And if the blood pressure is too high, hold the drugs until they get better control of it. Really simple, really easy, but it's something that we have to teach our patients before actually they get dosed the first time. Now, the diarrhea, we have to figure out, is it diarrhea related to the pembrolizumab or related to the lenvatinib? Immune-mediated diarrhea and colitis is among the most common immune-related adverse events we see in IO. Early GI evaluation, early corticosteroid use, really important to do. When I have diarrhea, when patients of mine, have diarrhea in this situation, then I stop the lenvatinib, see what happens. If they resolve, I know it's due to the lenvatinib. If not, it's due to the pembrolizumab treated appropriately.
Can you go back to that slide? I think this is really important, and I love that you have that up there, because that's a really key point. If the patient's diarrhea gets better after you institute and I actually tell them about the BRAT diet when they get the prescription. They get that, and we talk about loperamide and how to use it. And if it's diarrhea from lenvatinib, it'll get better with supportive therapy, which is very different than IO. And I think that's a really important point. So I'm just so happy you have this slide up there.
Yeah, no, and so we stop it and we can see, because it's tough to figure out. But no, thanks for acknowledging that. So what are some options? Let me talk to you about selinexor. Selinexor is an agent, it's a nuclear transport inhibitor. Okay, what it does is it prevents proteins from leaving the cell, from leaving the nucleus. While immune checkpoint inhibitors show significant benefit in DMMR tumors, it's still an unmet need in PMMR tumors. We know that P53 is a well-recognized prognostic marker for endometrial cancer, and I want to hammer home a point. P53 wild type is a biomarker that we could use to treat our patients. We shouldn't just think this mutation is something to do. Wild types could be something to do. Selinexor works by well, let me go through the data. This is the SIENDO data, randomized phase 3 trial. Maintenance setting, first line, carboplatin and paclitaxel. If they had a complete response or partial response, randomized to selinexor versus placebo in the maintenance setting. And here we could see from the primary study presented by, initially in the ITT, intent to treat population, there was no difference in all comers. But in a subgroup analysis, what we did, we looked at specifically the P53 wild type patients, those with a good tumor suppressor gene, and we found that the median progression-free survival was 13.7 months versus 3.7 months. Try to get FDA approval, the FDA said, let's do another study. Let's do the right study specifically looking at this. When we look at the long-term data, the hazard ratio of here is 0.76 in the P53, that's the overall survival data. When we looked at the median progression-free survival, 27 months versus 6 months, showing a benefit of selinexor here. Really cool data. Similarly, pMMR versus dMMR, pMMR population also showed a benefit, suggesting that in patients with pMMR wild-type tumors, there's still an unmet need with IO. Selinexor may be an option for these patients. We're doing this trial now. We have to go back to see if it actually works just in this wild-type group, and this is ongoing accrual trial of Export EC042, examining P53 wild-type tumors, maintenance setting, selinexor versus placebo. So this is, future directions, where are we going? This is really important because we talked about ADCs in ovarian cancer with mirvetuximab. We're excited about this as well. Here's some of the ADCs being evaluated, B7H4, folate receptor alpha, and the TROP2s. And then there's one TROP2 study that's in the public domain that's ongoing that we're enrolling to, so we're excited about that. Thank you.
Awesome. Thank you so much. That was great. And then Priya is going to come and present a case for us to get us started on the next module.
All right, so this is a patient that is actively on treatment. She had a few treatment choices that I had to make. She's 68-year-old, she's a pastor's wife, presented with postmenopausal bleeding, endometrioid, endometrial adenocarcinoma was diagnosed in September 2023. However, she was lost to follow-up and then got admitted in the hospital with abdominal distension, with a CT showing massive ascites, a 14-centimeter central pelvic mass, large adnexal masses, a mental caking, hydronephrosis. At that point, I got involved, and considering that this is unresectable, I started on treatment with carboplatin, paclitaxel, and bevacizumab. On her second cycle, while she's getting Taxol, just at the very start, she had a transient loss of consciousness. Her face fell backward on the chair, scared the treatment nurses. They abruptly stopped her paclitaxel. She had some low back pain, discontinued treatment. At the same time, her HER2 came back as 3+ positive, and I switched her treatment from carboplatin, paclitaxel, bevacizumab to carboplatin, paclitaxel with a lot of premedication and trastuzumab, and she thankfully tolerated that well. I was actually standing literally by her chair to make sure she didn't have a reaction to Taxol. She did have a PET after 2 cycles and had a partial response. That's where she is now. Her CA-125 dropped from 772 down to 228, so clearly responding to it. Given that she presented with ascites and she's also HER2 positive, I struggled if I made the right choice from switching her to trastuzumab as opposed to bevacizumab, and would love to know your thoughts.
Yeah, who wants to take this on? Maybe Flor?
Sure. So I think either one of our options. So in the data that we have for chemotherapy with trastuzumab is in uterine serous carcinoma. And that's in stage 3 or 4, first line. So that was better than chemotherapy alone. This patient had endometrioid. So and we're really starting to think more about these molecular subset for those patients who are endometrioid or anyone with a P53 alteration. Bevacizumab, there's some post hoc analysis and other data that suggests that bevacizumab may be more beneficial in that population. So I think both are reasonable options. Continuing to carboplatin with the paclitaxel bevacizumab, probably fine to continue to, and then holding, if she has a response, great, continue that. If she has a recurrence in the future, I would probably go to TDXD next, especially with HER2 3+, FDA on label with accelerated approval right now.
Okay.
Great.
Now that I've chosen the path of trastuzumab, how long should I continue trastuzumab? So let's say she has surgery. Would you take her for surgery? And yes or no? And regardless, how long would you continue trastuzumab?
Go ahead.
Good. Okay. Yeah, so this patient has not had surgery yet. At this point, I think there's some data out there for neoadjuvant chemotherapy in endometrial cancer. So if she has a response that she now becomes resectable, I think that would be absolutely reasonable to do. And even when we give chemotherapy for those patients that still have their uterus, even if they have a complete response everywhere else, I have not had a patient where they actually had a complete response in the uterus also. It seems to be something that there's always residual disease in the uterus, so I still think it's important to do a hysterectomy at some point if they have a good response elsewhere also.
And trastuzumab was continued until progression in that study. All right.
At what point would you incorporate TDXD? So let's say technically if she was allergic, so to speak, to Taxol, would you switch her to TDXD at that point?
If she's still, I would wait till she has progression. I would continue treating her with what we have and not switch her if she's responding to her current regimen.
If she had ovarian cancer, as opposed to endometrial cancer, and let's say she's folate receptor alpha positive and HER2 positive, how would you sequence between trastuzumab deruxtecan and mirvetuximab?
Ritu, do you want to answer that one?
Yeah, it's possible she might see both, and you might have to just look at the toxicity profile and see what's favorable. I don't know that we can say one's better than the other. I've had patients who have 100% alpha folate receptor expression and don't respond to mirvetuximab. I haven't had enough experience with trastuzumab deruxtecan yet, and to say something. I've had responses. I think it's reasonable to consider either, but you might have to just think about how you want to sequence them.
Then what point are you all testing for HER2, for endometrial, cervical, and ovarian? At diagnosis, on progression?
We can just do a show of hands. At diagnosis, audience participation too. At diagnosis for me.
Almost for everybody.
Definitely.
If we can, yes.
Yep. Okay. Mansoor, at diagnosis?
No, we don't, because we don't have a possibility to give trastuzumab. That's why we are not doing with that. As soon as we have that approval, we will be doing it. So we will add that in our guidelines.
Yeah. All right. Wonderful. Come on up, Eric. Eric's going to present a case. I do think HER2 has prognostic significance as well, so it may be helpful in terms of counseling. All right, Eric, thank you so much.
Okay, this is a case that I really need help from the faculty for. Young lady, 36-year-old, diagnosed with a mucinous adenocarcinoma of the ovary, large ovary large tumor, huge tumor, 20 centimeter encasing left ovary. She had surgery in last year, 2023, a significant delay of care due to lapse of insurance. She was referred to academic center. She did not receive high-PEC or adjuvant chemotherapy due to lapse of insurance. And when she established with me, at that point, she had been diagnosed with a liver metastasis. I sent for an NGS at that point, but because she had symptomatic disease and given the mucinous histology, I actually started her on a GI-type regimen. So I started her on capecitabine, oxaliplatin, and Bev. Subsequent NGS showed an ERBB2 overexpression. She has a KRAS mutation, TP53, BRCA1 and 2 negative, HRD not detected, low TMB. And so she had just started therapy. I actually referred her to GI for endoscopy to rule out a GI primary. Her staging scans do not look like a GI primary, however. And I'm thinking about adding on a HER2-targeted therapy for her given to ERBB2. I have requested IHC because technically the TDXD approval is on IHC, not on NGS, although I do believe an ERBB2 amplification would likely be a HER2 positive. Just wanted to check to see what the faculty would, how would they manage this?
Yeah, this is great. So our only site of recurrence is in her liver, and it's liver mets?
As far as I know, it looks like isolated liver metastases, correct.
All right. Is she amenable to a surgical resection? I mean, that would be one of the first things I would think about. What about the panel?
It's unfortunately a multifocal liver metastases. So she probably has peritoneal disease, is not picked up very well on the staging scans. Very high CA-125. I do suspect she probably has peritoneal disease, but it's not always picked up very well. Mucinous histology is very difficult to pick up on imaging, and we can't always see it on imaging. But very clearly, and these are like intraparenchymal metastases in the liver. So a little unusual. You would think that mucinous histology should be a surface implant, right? But this is actually within the body of the liver. Yeah, it's a little unusual. So it was a percutaneous biopsy, not of a surface implant. It was actually within the liver.
Floor's ready.
Yeah, it's a little strange for this case. It's a very interesting case, and these are so hard to treat. But the fact that she has a KRAS and a P53 alteration is strange. And that doesn't make a whole lot of sense. Usually those don't go together. That makes me think low grade,
I really wonder whether
grade,
it's a GI primary technically. But then the surgical pathology from her surgery originally did look like an ovarian mass. So
yeah. Yeah, it may be worthwhile to stick in a pathology review, or at least getting it for her, if her disease, bulk of her disease is in the liver, to get a new biopsy and get that tested too, if the previous NGS was from her ovary.
No, the NGS is from the liver biopsy, actually.
That is from the liver. Okay, interesting.
And so, Brian, what are your thoughts? You don't have IHC data, but you have evidence of alteration, or BB2?
Yeah, I would start with trastuzumab deruxtecan on her. I think it's a no-brainer at this point, to be honest with you. I think with the amplification, I think you have a good chance of responding. And then I think there's a next line of therapy. I don't think she's ever received a taxane at all.
No.
So I think next line of therapy after that would probably be just Taxol Bev.
Carbotaxol.
Well, she had the Oxali, so didn't she have the GI regimen of a? What did she have?
She had
platinum at all?
I think she received oxaliplatin.
No.
Okay.
I do think it's really important to complete
Well, she's on oxaliplatin right now. I started her on capecitabine oxaliplatin, and she's just gotten going for like a month and a half. Just started.
And Ritu has something.
I do think it's important to work up the GI, though, just because you don't see anything on imaging. There could be an occult malignancy.
Yeah, we're waiting for that.
Appendix is always
her coverage is
that,
very challenging. Yeah.
Yeah, we often treat these like adenocarcinomas of unknown origin. If it doesn't really match a ovarian profile, which I don't know that this does.
And I think your last two questions there, Eric, are really important in terms of monitoring for interstitial lung disease. And Mansoor, do you want to take that on? As well as the other question about when do you discontinue therapy?
So we tend to be very careful, and we usually pick them up in grade 1. We are very fortunate we did not have high grade.
At what level?
We are quite quick to do CT scans and everything, so that makes it possible.
At what level? Go ahead, Eric.
Do you do more frequent chest CTs, or do you just rely on symptoms from the patient and do standard of care staging for the cancer?
You have to do CT scans for TDXD, because grade 1 would be an asymptomatic, and you would already need to hold. Right. Once you get to grade 2 and they have AND changes and they're symptomatic, you need to permanently discontinue the drug because they go quickly to progression and death. So absolutely, you have to do CT scans.
So do you follow like every 9 weeks, like on a trial? Is that how is that your standard of practice?
Every 8 to 12 weeks, yeah.
Mm-hmm.
Yep.
That was a perfect segue. Thank you. Are you guys ready? Last part. Or do you have? Yeah, so last part, because we're running a little bit behind. So I'm going to talk about the role of HER2-targeted therapy in advanced ovarian and endometrial cancer and other gynecologic cancers. How many of you have utilized HER2-directed therapies in endometrial cancer? All right, a few, yeah. I don't know if everyone's just so tired you can't even raise your hands anymore, but we're going to talk about this. So our objectives are to discuss testing, the frequency of high HER2 expression in advanced gynecologic cancers, and when and how you would test. A perfect question that was brought forward by Priya. Review the HER2-targeted strategies such as trastuzumab and trastuzumab deruxtecan, as well as some other therapies out there right now, and review the safety profile of TDXD toxicities, recommendations for monitoring and management. So Eric's case was perfect. All right, so we have a 56-year-old female patient with recurrent BRCA wild-type HRD positive high-grade serous ovarian cancer who presents with extensive ascites, a pleural effusion, hepatic mets, who progressed on second-line PLD and platinum-based therapy. So what are your treatment options? Would you utilize mirvetuximab, paclitaxel with bevacizumab, or trastuzumab deruxtecan, or clinical trial? Clinical trial is always the right answer, but all of these options could be possibilities. So what's the most important thing here, Brian?
Yeah, I think that these patients, you want to know what some of her molecular profiling is. Do you want to know if there you go.
There we go. It is critical to do testing for these patients. So I just gave some examples, so cervical cancer, PD-L1, the middle one is endometrial cancer, DMMR, and P53. I have germline testing for ovarian cancer, but HRD is important. NGS can be important in some cases, folate receptor alpha. It's incredibly important to test these patients so you can choose your next line of therapy. We live in an exciting time, but we're going to focus on HER2. And one of the questions was HER2 testing, and my response to that is it is complicated. I didn't realize how complicated it was until trastuzumab deruxtecan became available for us to utilize in the clinic. But there are at least 5 different ways that you can do your assessment for staining. And the study or the staining that we utilized for the pan-tumor destiny trial was a gastric staining, which is less robust than some of the other staining. So one of the first things I think we should all be doing is talking to our pathologist and see what type of staining they utilize. There's not a companion diagnostic or a companion biomarker with this drug, which in my opinion, I think is actually a good thing. So we can talk about that further as well. So let me just breeze through very quickly about HER2 expression in the various cancers. So in ovarian cancer, the highest expression is in mucinous carcinoma. So it's a perfect case illustration by Eric there for his patient. Protein overexpression can be seen in 30%, amplification anywhere from 25 to 35%. Gene amplification in the other ovarian cancer cell types is very mixed, anywhere from 12% down to 2%. And there's a lot of intratumoral heterogeneity in HER2 protein expression that's seen in about 20% of cases. HER2 is a prognostic factor. It's associated with worse progression-free and overall survival. And the very first study that we did through the GOG on biologic therapy was evaluating trastuzumab in patients, and they required 2 or 3 plus staining, and 837 tumor samples were screened to identify 95 patients who exhibited 2 plus or 3 plus, 11.4%. And 41 patients went on the study, and the objective response rate was 7.3%. It was very sad. I think we're all excited about the biologic therapy, but more to come on that. In endometrial cancer, it really varies across the different histologic subtypes. The overexpression and amplification can range anywhere from 4% to 69%. We utilize testing in patients who have serous carcinomas and carcinosarcomas in the initial diagnostic setting. And this was work that was done by Dr. Erickson showing the prognostic significance of HER2 positive cancers had on progression-free survival with a 3.5-fold increased risk of progression and 2-fold increased risk of death. And there's a higher frequency of HER2 overexpression in Black patients compared to white patients. And in cervical cancer, protein expression is around 38.7%, somatic mutations in HER2 in about 5%. But there's a lot of variability. And again, you see that role in terms of the prognostic significance for survival. In the phase 2 Summit basket trial of neratinib in patients with HER2 mutant metastatic cervical cancer, there was only 16 patients on this trial. The objective response rate was 25%, but there was significant clinical benefit in about 50% of patients, and the duration of response ranged anywhere from 5.6 to 12.3 months, with a PFS of 7 months and overall survival of 16.8 months. And carcinosarcomas, really conflicting literature there, ranging anywhere from 3 to 56%. One of the studies here utilized the 213 ASCO CAP criteria, and about 16% of patients with carcinosarcomas had HER2 positive expression. The rate tends to be higher in uterine versus ovarian cancers with regard to the carcinosarcoma histologic subtype. And HER2 tumors either had a serous or a mixed carcinomatous component. All tumors with endometrioid, clear cell, undifferentiated, or neuroendocrine carcinoma subtype were HER2 negative. And a huge gap right now that we have is we don't completely understand the overlap between these different biomarkers to help direct the landscape of clinical trials or to direct treatment sequencing discussion. This is a study that was alluded to earlier when Priya presented her patient. And this is a study that was conducted by Dr. Amanda Nichols-Fader with Dr. Alessandro Santin. And patients on this trial had to have stage 3 or 4 recurrent disease and HER2 positive testing with either 2 to 3 plus or 3 plus, and if it was 2 plus, they had to have positive FISH. And what you see here with these survival curves is the yellow line shows the patients that received trastuzumab, that there was a significant improvement in progression-free survival with a greater than 50% reduction in disease progression compared to the patients that received chemotherapy alone. And overall survival was also improved, which was really important because this study was really an investigator-initiated study, and I'm always a little concerned. It's not as robust compared to a cooperative group or pharmaceutical trial. This led to listing in the NCCN guidelines. Another trial, the TAPER trial, evaluated pertuzumab and trastuzumab in endometrial cancer, and you see from the waterfall plots that you had a nice disease control rate of 37.2%, and it appears that some patients had long-lasting and durable responses based on those spider plots. And the STATUS trial evaluated trastuzumab deruxtecan in patients who had uterine carcinosarcoma, and gorgeous waterfall plots with tremendous responses in the HER2 high group, which is the top graph, as well as HER2 low. So very exciting there that this would be an option for patients regardless of expression. All right, Destiny PAN-202 trial. How many people have seen this study? I'm sure you've seen it a lot. We love it. And what you see here in this evaluation is that patients who had 2 or 3 plus cancers, endometrial, cervical, ovarian cancer, treated with this drug is that it works. There's long-lasting responses and pretty deep responses. The progression-free survival and overall survival curves shown by the blue line here, all patients who had 3 plus IHC had better survival outcomes than the other 2 categories. Now, in terms of toxicity, the toxicity we really want to talk about is the ILD or pneumonitis in about 11% of patients on this study. It's really important to monitor closely for toxicity. And a lot of times you're not going to pick it up on the patient complaining. You might pick it up on a CT scan. This next slide addresses Eric's comment regarding activating HER2 mutated cancers. This was just published recently from the PAN-Tumor01 study. There was only 6 patients with gynecologic cancers, and of those 6 patients, you see nice responses, and several of those patients that are quite durable. And so it's really nice to see that this opportunity may be opening up for a tumor-agnostic indication for the HER2 mutated cancers. All right, back to lung disease. This was a meta-analysis that was conducted. I think an important aspect here is understanding those patients at highest risk. So age, enrollment in Japan, the dose of therapy, so higher dose, more likely to have toxicity, oxygen saturation levels that are low, moderate or severe renal impairment, or already underlying comorbid conditions with regard to pulmonary disease. These are really 2 important papers. I think you should read them. I plan on having a very close review of them as well in the breast cancer literature by Dr. Rugo, one discussing real-world perspectives and practices, and then the ESMO one regarding optimizing treatment management. They have a beautiful chart in here regarding how to monitor these patients, pulmonary consultation, PFTs, discontinuation of therapy are all outlined. So NRG GY026 is a randomized phase 2 study right now evaluating trastuzumab as well as a combination of trastuzumab, pertuzumab in patients with serous cancers. And then another study is a HER2 targeting agent in advanced solid tumors, again showing this tremendous improvement in response rates. And guess what? Live from Chicago, we're finishing up on time. So thank you all for being here with us tonight. And to our wonderful faculty members, thanks to you all for your expertise. It's really amazing to have such leaders in the field here all on stage together. And then I just can't thank Lyndsay, Eric, and Priya enough for coming up here and sharing your patient experiences with us. And I know we ran out of time. If you all have questions, I'm happy to stay around. I know we had some audience questions, and I'm happy to answer them for you. Thanks again. Enjoy the rest of your meeting.
Thanks.